In this lecture, we will discuss the basic EKG changes seen in the setting of myocardial ischemia and infarction. The EKG is a cost-effective tool in providing incredibly valuable information of the diagnosis, prognosis, and treatment of acute and chronic myocardial ischemia. In the setting of acute myocardial ischemia, it can help identify the location, extension, and time course of the ischemia. Myocardial ischemia and infarction affect different areas on the EKG. Because myocardial ischemia mostly affects myocardial repolarization, we can see these changes in the ST segment and T wave, which are referred to as STT changes. And because myocardial infarction mostly affects myocardial depolarization, and since dead cells don't depolarize, we will see these changes in the QRS complex. Okay, so again, the main thing I want you to take away right here at this point is that the QRS complex that represents ventricular depolarization, we tend to see these issues here in or changes there in infarction, okay, because dead cells cannot depolarize. Now, in terms of ischemia, we tend to see these changes in the ST segment, okay, and our T wave. So this region here, we call those STT changes, okay, and that's in the setting of ischemia. So ischemia, the STT changes, and infarction, we'll tend to see QRS changes, okay, because of that dead tissue. Now, the classical STT changes in myocardial ischemia include ST segment deviation, such as ST elevation or ST depression, as well as T wave changes. And we said that we refer to these as STT changes, okay? In general, ST segment deviation suggests that there is acute or ongoing ischemia, and it is often accompanied by the T wave changes. The T wave changes may manifest as inverted T waves, flat T waves, which have a low amplitude, or hyperacute T waves, which have a large amplitude. One thing to note is that the isolated T wave inversions or flattening, that is, those that do not occur with any ST segment deviation, are not signs of acute myocardial ischemia. Rather, these occur after an ischemic event. We refer to these as post-ischemic T wave changes, as post-ischemic T wave inversions, or post-ischemic flat T waves. There's one scenario in which isolated T waves may in fact suggest ischemia, and that's Welland syndrome, which we will discuss in another lecture. Now, if you see isolated hyperacute T waves, which are very broad and tall T waves, they may actually be a sign of myocardial ischemia. So let's just look at some of these examples, okay? So again, down here we have acute ischemia, okay, where we can see the ST depression and T wave inversion, okay? Below that baseline, we see a ST depression and the inverted T wave, okay? The hyperacute T waves, which we have here, notice that this is our T wave, okay, and it's very large, tall, symmetric, and it has this broad base there, okay? So those are hyperacute T waves, and when we talk about ST elevation, here's our baseline. There's a number of different ST elevations. This is our J point. You can see that it's above that, okay? So again, that's ST elevation. We're going to take a look at some of these as we move forward. Now, while these changes may not be specific to myocardial ischemia, in the presence of chest discomfort, these STT changes strongly suggest myocardial ischemia. Examining the morphologic STT changes can often help lead us to a diagnosis. And what we will see is that the EKG changes will also assist us in localizing the site of ischemia, determining the extent of ischemia, as well as where in the ischemic time course we are. This is because the earlier and later phases of ischemia differ on the EKG. So that is ischemia, and we will look in detail at these STT changes in the ischemic lecture as we move in another lecture, okay? Now let's look at myocardial infarction. So we said that myocardial infarction primarily affects myocardial depolarization, okay? And that's that QRS complex. The most characteristic finding here is abnormally large Q waves, which are also referred to as pathological Q waves. There are also pathological R waves that we will look at in another lecture. We can also see fragmentation or notching of the QRS complexes, as well as a reduction in the R wave amplitude due to a loss of viable myocardium. And as we mentioned above, isolated T wave inversion or flattening may be seen, representing post-ischemic T wave changes. But the main thing I want you to take away here is that myocardial ischemia mainly affects the STT changes, okay, and the myocardial infarction appears mainly as QRS changes. So let's take a look at some of these changes in ischemia and infarction. Okay, so first off, these are the post-ischemic T waves. Notice you have these T wave inversions, okay, and you can have these flat T waves. And we'll talk about these as we talk about T waves in another lecture, but notice that those are just some changes that we can see after infarction. Okay, this would be an acute ischemia where we see also ST depression with the T wave inversion. Okay, so notice in these cases we had a normal ST segment. Okay, and hyperacute T waves, that can be a sign of acute ischemia. And then we can have these different morphologies of ST elevation. Okay, so here's our row of ST elevation, and this would be the ST depression. Okay, so these are signs of ischemia. So this is a convex, okay, ST elevation, and that's based on, you can see this line here. Notice how it's curving this way. That's called convex. There's also concave if it would go the other way. Okay, so convex, think of it going down as a sad face, so that's a sign of ischemia. And then we have these straight upsloping ST elevation. So again, notice from here we have upsloping ST elevation, it's going upwards. Okay, then we can have straight horizontal, where we have ST elevation, but it's flat there. And then we can have straight downsloping, where again ST elevation, but now it's going down. Okay, all of these are signs of myocardial ischemia. Okay, now in terms of the ST depression, we can again have different morphologies where we can have downsloping. So again, below our baseline, so we have ST depression, and now it's going down. We can have ST depression that's horizontal in nature. So here's our baseline. You can see that it's below our baseline, okay? And we have a horizontal ST segment there. And then we have these pathological Q waves, okay? And this would be, imagine we had our P wave here, and then this here is our Q wave, okay? And this is a pathological Q wave. We'll talk about these in a future lecture, as well as pathological R waves. But what you have going on is that these Q waves are not only wide, but they're also deep, okay? And you can sometimes see them as just QS complexes. A QS complex is simply when you have a only negative deflection in our QRS of our QRS waves, okay? So this would be called a QS complex. Okay, so those are the various morphologies, and we'll discuss a lot of these in more detail in future lectures. So let's briefly review what we discussed before we end. So again, the EKG is really a cost-effective, valuable tool in making the diagnosis, predicting the prognosis, as well as the treatment in ischemia and infarction. It allows for localizing, determining the extent, and time course in ischemia, okay, because different changes occur early on versus later, and we'll go through the EKG progression during these time phases. Myocardial ischemia, remember, this is one of the main takeaways I want you to get from here, is that ischemia affects the ST and T segment, okay? So that's the ST segment and the T wave are the ones that are affected mainly. In myocardial infarction, it's the QRS changes, okay? Remember, dead tissue does not depolarize, so that's why we see those Q waves occurring in those cases, all right? Or reduction in the R waves because we have dead myocardium. Okay, now we talked about all these ST segment changes and deviation. It could be elevated, it could be depressed. Then we looked at all these different morphologies, okay? Then we said these T wave changes could be inverted. We saw an inverted T wave, okay? We saw a flat T wave, no T wave there, okay? And then we looked at these hyperacute T waves. As long as they're accompanied by these ST segment deviations, then that will suggest ischemia. But them present alone, all right, does not tend to suggest ischemia. Okay, we can see those in post-ischemic T waves, which again, the T waves that are inverted are simply there because and indicate that ischemia occurred in the past. Okay, it doesn't suggest that it's acute or ongoing. There is one exception that we'll talk about, Welland syndrome, in future lecture. Okay, we talked about these hyperacute T waves that are isolated, and what we can see here are they suggest ischemia. They're large T waves that are broad and tall. Okay, and then remember, these STT changes are non-specific, but if you have a patient that's symptomatic, has chest pain, then they likely suggest ischemia. In terms of infarction, remember, it's the QRS changes because depolarization is the main thing affected. We can see these pathological Q waves and R waves. You can see some notching or fragmentation in our QRS complex, as well as a reduction in the R wave amplitude. Well, that's the end of this lecture. We discussed the basic EKG changes seen in the setting of myocardial ischemia and infarction. I hope you learned something.